Um, to be honest, we don't really know how conjoined twins are formed. But to give you an idea of what we know is, the phenomenon of fertilization when a sperm and an egg meet and form what is called a fertilized egg. Now, the fertilized egg is composed of cells which are called totipotent cells. The word totipotent means each cell is capable of forming a baby on its own, which is itself a big miracle. Now, this cell starts dividing rapidly, and about 15 to 17 days after the fertilization takes place, in some babies, for an unexplained reason, this mass of cells divides into two. So you start getting two babies in the place of one. But these two babies are what are called identical babies because they share the same living space, they share the same blood supply, and they are believed to mirror each other very closely. Now, if for some unexplained reason, these two masses of cells which split, if they rejoin, then you get what is called conjoined twins. But conjoined twins can fuse at any level. They can fuse at the head, they can fuse at the chest, that is the commonest. They can fuse in the belly, which is the second commonest. They can fuse completely over the back. They can fuse in the buttocks also. And each of them has got a Greek term which explains this particular fusion. So this is conjoined twinning in brief. Yeah, absolutely. With the amount of ultrasound technology that is available today, which is both three-dimensional and even four-dimensional, it's perfectly possible to detect that you have conjoined twins. But unfortunately, for instance, if you take it in our country, conjoined twins are not that common. Even twins per se are not common in our country. Where it is common is Southwest Asia and Africa, and we really don't know the reason why it happens. But on the whole, if you want a rough idea, conjoined twins happens in somewhere around 1 in 2 lakh to 1 in 10 lakh live births. But it is possible to detect them in utero. It all depends on where they are fused. For instance, in the condition where they are fused at the chest, which the Latin name for which is thoracopagus, which is the commonest, they actually can share a heart. And as you know, when they share a heart, what really happens is the babies have severe anomalies, and most of the time they die. Separation is fraught with great risk. Invariably, one twin dies. If they share the abdomen, which means they can share the liver, they can share the intestine, and they can share most of the vital organs in the abdomen. This basically means that when you separate them, you have to decide which one goes where. And the concept of what is called the better twin and the less twin then comes into play. It becomes a very complex decision making. More difficult is when they share a back. When they share a back, what happens is often the spinal cord is fused together and separation becomes extremely risky. There is another condition called pygopagus where they are fused at the buttocks. When they are fused at the buttocks, the tail end of the spinal cord is one. They share a common excretory passage, which in medical term is called the rectum and the anus. And they also share a common genital system, which means the urinary passage and the phallus in males becomes one. So separation becomes a very complex affair. The most difficult and the most dangerous is when they are joined at the head, when parts of the brain are fused together, and that's called craniopagus. So yes, in summary, vital organs are certainly shared in conjoined twins. I wish it were short, but Ericana and Elodie are going to take us something like around 18 hours, perhaps slightly longer to separate. It's going to be a complex dance. Both are lovely babies, and we have become very fond of them over the last 5 months. They are fused at the back, which means the tail ends of the spines are joined. So we are going to ask the neurosurgeons to separate the spines first. Then we will go in layer by layer. And the next thing that we will encounter is the fused rectum and anus, which our pediatric gastrointestinal surgeons are going to separate. Now, it's not merely separating two structures that are fused. What we have to do is get the muscles around, the appropriate muscles, so that they have continence tomorrow. The word continence means they should be capable of functioning like you and me, being able to have control over their bowel movements. Next comes the most difficult part. They are sharing one common phallus. So we have to separate. So both Ericana and LOD have a viable and a good phallus which can be used both for urination and sexual activity later on. We have to separate their urethral passage, and probably some of the tubes that come from the prostate and from the seminal vesicles have to be identified and separated. Then we will have to separate their muscles, which are the gluteal muscles, the buttock muscles, then the whatever remaining parts of the ischial bones, which are the hip bones that are joined, and finally the babies will be free. But we won't be finished at that particular stage. Then the arduous process of putting them together again comes, which means we have to resuture everything together in its appropriate place, and finally you will have a large skin defect which has to be closed. So that's why I give you a time limit of around 18 hours, but it's not one person who's going to be doing it over 18 hours, it's going to be a group of people. We've put together a very talented bunch of people. We have the neurosurgeons, a couple of neurosurgeons led by Suresh Bapu, who's going to attempt the spine separation. And once the spine is done, and the terminal part of the spinal cord has something called the cauda equina. The cauda equina in English terms is horse's tail. So you have a whole bunch of nerves which come out at the end, and so he will use the microscope and separate the various nerves that go to each baby. And once he is done, then we have Dr. Radhakrishnan, Dr. Rajiv, who will separate the rectum and the anus and try and get the muscles of continence around. Then I will join with Dr. Thirumala Ganesan, and we will do the arduous process of separating the penis into two functional penises. We will separate the urethra all the way down to the bottom. We will separate the scrotum and the testes, and after that Dr. Roshni and Dr. Shivakumar will get together and finish the rest of the separation. Then we will all join together and help Roshni and Shivakumar put back all the structures together. So this is the way we are going to do it. For all this, we have also elicited the help of one particular surgeon from Great Ormond Street. This is Mr. Edward Kiley. He is a very senior pediatric surgeon from Great Ormond Street. He was trained in Johannesburg in South Africa, and he has an experience of around 20 conjoined twin separations. So we thought his advice and his help would be invaluable in this very important surgery. I think when we got them, they were each of them were 4 kilos. What we did initially was we studied their anatomy in great detail, for which we had to do 3-dimensional CT scans and also MRI scans. And we had the help of a wonderful radiologist called Rochita Ramanan, who's a wizard at doing a 3D reconstruction. And what she is very good at doing is she can, on the computer, actually virtually peel off the various layers and show you what you will encounter underneath. Something that has been extremely useful for us in planning the surgery. We also have our pediatrician, Dr. Lata Vishwanathan, who's looked after the babies with great care. And as a testimony to the care that she has given, the babies are each 8 kilos now. So they have really grown and blossomed under her care. She's taken care of all the minor infections that they've had, and given them the appropriate immunizations and made sure they are healthy and happy. In between all this, what we have done is we have also put what are called tissue expanders. Since the babies are joined over a large area at the back, we need extra skin to cover the defects. So our plastic surgeons have actually put what are called tissue expanders, gradually expanded them over a period of time. So if you were to see the babies now, you would find big bumps at the back. And this is where the skin has been expanded. So when we finally separate them, this extra skin will be very useful to cover the areas. So in the last 5 months, the babies have had something like about 8 or 9 anesthetics. I think that's quite a difficult question to answer. Once the babies are separated and they are out of the ICU, we will monitor them and see how they are as far as their passing of urine and passing of stool is concerned. We actually have done what's called a diverting colostomy for them, which means they're passing their stool from the tummy. So where we are going to do this extensive reconstruction, we are going to keep that area free of feces for fear of contamination. So once the babies are able to pass urine well, and they're able to move their legs well, and they get used to a life without being restricted by being attached to the other baby, I think we'll discharge them. We're looking at about 6 to 8 weeks of stay in the hospital after they are separated. Then they will go home to Tanzania to the father and also to their elder sibling who's waiting for them. We have asked them to come back about 6 months later when we will reconstruct the penis again. In the process of separation, what we are going to do is the urinary opening, the urethra is going to be at the base of the penis, and that's called a hypospadias in medical terms. We are going to reconstruct that, give the baby a fully normal penis. This is going to take another 2 to 3 weeks to do. Then we will close the colostomy, which means the babies will be able to stool from below. We will re-look and re-evaluate them to see how their pelvic anatomy is, how the muscles at the back are, what sort of stool control they have. We'll also see what the functional effect of the reconstruction is, whether there are any scars need to be excised, anything needs to be adjusted. So I think we will be seeing Ericana and LUD at least for another 2 years, on and off. I'm Dr. Sripathi. I'm a pediatric urologist. A pediatric urologist is somebody who deals with the urinary tract of babies and children from birth till about 18 years of age. Children have a lot of things that can go wrong with the kidneys, the tubes that come down from the kidneys, the bladder, the genital organs, which is the testes in the male, the ovaries in the female, the external genitalia, and so many other issues which pertain to the urinary organs. Almost 40 to 50% of all the surgical conditions that can affect babies belong to the genitourinary tract. So pediatric urology is a full-fledged specialty which deals only with these problems. A very interesting part of our specialty is we counsel women who are pregnant, and we tell them that if you have a problem, what will be the outcome when the baby is born? How exactly do we go about correcting it? It's our responsibility in a single line, and it's our responsibility to make sure that the baby is healthy and happy till they reach about 18 years of age when we hand them over to our adult counterparts.